Anatomy of the salivary glands. First comes the parotid gland. It is the largest salivary gland. Average weight is 25 grams. It is irregularly lobulated, resembles a three-sided pyramid. It is a wedge shape in the coronal section, contains mainly the serous acinus and the few mucinous acini. Here we can see this is the parotid gland, and this is the Stensen's duct, opening into the second upper molar. Now, the parotid gland is situated below the external auditory meatus between the ramus of the mandible and the sternocleidomastoid muscle. Well, in the relationship, there are 4 surfaces and the 3 borders. The 4 surfaces, the superior, which forms the base of the pyramid, the superficial, anteromedial, and the posteromedial. The borders are the anterior, posterior, and medial. Now, if we talk about the superior surface or the base, it forms the upper end of the gland, which is concave and small, and it is related to the cartilaginous part of the external auditory meatus, posterior surface of the TM joint, temporomandibular joint, the superficial temporal vessels, and the auriculotemporal nerve. So this is the superior part of the parotid, concave shaped. This is the external auditory meatus, the superficial temporal vessels, and the auriculotemporal nerve. The relationship. Then comes the superficial surface. The superficial surface, there is the skin, the parotid fascia, the posterior body or the posterior border of the platysma. Some branches of auricular, the great auricular nerve, and a few deep parotid lymph nodes. Here we can see the skin, the superficial fascia and the platysma, and the great auricular nerve. So this is the superficial surface: skin, superficial fascia, the platysma, the great auricular nerve, and the some parotid nodes. Now the anteromedial surface. The anteromedial surface, basically the masseter. The relations anteromedial surfaces are 3: the masseter, the lateral surface of the temporomandibular joint, the posterior border of the ramus of the mandible, and the medial pterygoid. So as we can see, this is the anteromedial. So this is the parotid. The facial nerve is passing, which is basically divides the parotid into superficial and deep lobes. And anteromedial, we can see there are the masseter, the lateral surface of the TM joint, the posterior border of the ramus of the mandible, and the medial pterygoid. It can be seen here. This is the anteromedial surface. This is the posteromedial surface. So anteromedially we can see the ramus of the mandible, the medial pterygoid, and the masseter muscle. Whereas the posteromedially we can see its relationship, the mastoid process. The mastoid process with the sternocleidomastoid and the posterior belly of the digastric. This is the sternocleidomastoid and the posterior belly of the digastric. And we can see the styloid process. The styloid process with the 3 attachment of the muscles, the EAC. The styloid process with the 3 attachment, the EAC. The EAC enters the gland through this surface. ECA. So the external carotid artery enters the gland through this surface. This is the internal carotid artery lies deep to this, the styloid process. So this is the internal carotid artery which is lying deep to the styloid process. This is the styloid process. So this is the anteromedial, this is the posteromedial. So as we say, the posteromedial surface, it is in relation to the mastoid process with the sternocleidomastoid and the posterior belly of the digastric. The styloid process with the 3 attached muscles, the external carotid artery enters the gland through this surface, and the internal carotid artery lies deep to the styloid process. You can see in this diagrammatic representation. Now we talk about the borders. The borders anteriorly it overlines the masseter muscle. So the anteriorly it overlies the masseter muscle. The posteriorly extends below EAC and into the mastoid process, overlying the lateral process of the C1. Medially it fills the gap between the mandible anteriorly and the mastoid and styloid process. It extends close to the lateral wall of the oropharynx. Now the accessory parotid gland, it is a separate part of the gland lying on the masseter muscle above the zygomatic arch below the parotid duct. The parotid duct is about 5 cm long, emerges from the middle of the anterior border of the gland and runs forward and downwards on the masseter At the anterior edge of the masseter muscle, the stenosis duct turns sharply medially and passes the buccinator muscle. Buccal mucosa and opens into the vestibule of the mouth opposite the crown of the upper second molar. Here we can see this is the accessory parotid gland, this is the main parotid gland. This is the stenosis duct which is moving over the masseter, then piercing the buccinator, opening into the second upper molar. The capsule. The gland is encapsulated by a deep cervical fascia. The deep cervical fascia splits to surround the gland and is known as the parotid fascia. The facial envelope is continuous. The facial envelope is continuous anteriorly with the fascia covering the masseter, such as the peridomastoid, and extend up to the zygomatic arch. So one need to understand that the facial envelope is continuous anteriorly with the fascia covering the masseter muscle as the peridomastoid and extend up to the zygomatic arch. Deep part of the extends to the base of the skull and is thickened between the styloid process, tympanic plate and angle of the mandible and forming the strong stylomandibular ligament. The stylomandibular ligament portion of the deep cervical fascia separates the parotid and the submandibular gland. So the stylomandibular ligament separates the parotid and the submandibular gland, which is a part of the deep cervical fascia. Now relationship with the facial nerve. The emerges at the level of the digastric muscle. So the facial nerve emerges at the level of the digastric muscle. Through the stylomastoid foramen, main trunk divides with the substance of the parotid gland into the upper zygomatico-temporal and the lower cervicofacial divisions. Each division then further subdivided to form the total 5 branches: the temporal, zygomatic, buccal, marginal, mandibular and the cervical. Before it enters the gland, it gives off the 3 branches: the posterior auricular, the posterior digastric and the stylohyoid branch. Now here we can see the parotid gland is divided by 2 parts by the facial nerve into 2, the superficial part and the deep lobe. Now this is the CATZ and the CATALANOs describe the 5 patterns of the branching. In type 1 it is 25%. No anastomotic links between main branches, but there is a splitting and reunion of the zygomatic and the mandibular branch. In type 2, which is 14%, the buccal branch subdivides and fuses with the zygomatic branch. In type 3, the major anastomotic links between the buccal and other major branches. Type 4, there is a complex branching and anastomotic links between the 2 divisions. In type 5, the facial trunk divides before leaving the stylomastoid foramen, which is the rarest. So here we can see how the main trunk is dividing into zygomatico-temporal branch and a zygomatico-facial branch, which is further divided into 5 branches. Now the parotid anatomic autonomic innervation. The preganglionic secretomotor fibers are carried from the inferior salivary nucleus, 9th cranial nerve, glossopharyngeal, tympanic branch, and through tympanic branch and tympanic plexus into the medial part of the middle ear. It passes in upper roof. The lateral petrosal nerve relays to the otic ganglion. And the postganglionic parasympathetic leaves the otic ganglion and distributes to the parotid gland via the auriculotemporal nerve. So the preganglionic secretomotor fibers and postganglionic parasympathetic fibers. Preganglionic are by the vasopetrosal nerve, whereas the postganglionic by the auriculotemporal nerve. The sympathetic vasomotor are from the plexus around the external carotid artery. Now comes the blood supply. The arterial supply is by the branches of the external carotid artery, whereas the vein is by the retromandibular vein and into the external jugular vein, and via the facial vein into the internal jugular vein. So main venous supply by the retromandibular vein into the external jugular, and facial vein by the internal jugular. Now the lymphatics of the parotid. Lymph nodes within the gland drain the parotid gland, the nasopharynx, palate, middle ear and external auditory meatus. So the lymph nodes within the gland drain the parotid gland, the nasopharynx, the palate, the middle ear and the external auditory meatus. The interparotid lymph nodes drain into the superficial and the deep cervical nodes. Now the parotid bed, deep lobe lies on the internal jugular vein. The external and internal carotid arteries, the glossopharyngeal nerve, vagus, spinal accessory, and the hypoglossal nerve, 9, 10, 11, and 12 nerve. The styloid process, the styloglossus, and the stylohyoid muscle. Well, if you talk about an applied anatomy, the parotid swellings are very painful due to the underlying nature of the parotid fascia. Mumps is an infection of the salivary glands caused by the paramyxovirus, which will cause a severe pain. When the Frey syndrome, also called the gustatory sweating, it is a complication of the parotid surgery. It is characterized by the sweating and flushing of the preauricular skin during the mastication. It is a result of the aberrant innervation of the sweat glands by the parasympathetic secretory motors, which are destined for the parotid. So, aberrant innervation of the sweat glands by the parasympathetic secretory motor, which are supplied by the lesser petrosal nerve, which were destined for the parotid. So, now let us talk about a submandibular gland. It is the second largest major salivary gland. It is irregular in shape and weighs about 7 to 16 gram. Which side? It lies in the submandibular triangle. It lies in the submandibular triangle formed by the anterior and the posterior belly of the digastric muscle and the inferior margin of the mandible. Consists of the large superficial and a deep, small deep part wrapped around the posterior border of the mylohyoid. The posterior superior portion of the gland curves up around the posterior border of the mylohyoid and give rise to the Wharton's duct. So the posterior superior portion of the gland curves up and around the posterior border of the mylohyoid and give rise to the Wharton's duct. Here we can see this is the deep lobe of the submandibular gland. This is the superficial lobe. Lies on the submylohyoid muscle, deep inside and superficial outside. And the duct, the posterior superior portion of the gland, it curves up. The posterior superior curves up around the posterior border of the mylohyoid and give rise to the Wharton's duct. This is the Wharton's duct. Now the superficial part, derived from the deep cervical fascia, it covers by the skin platysma and the fibrous capsule. Superficial layer of the fascia covers the inferior surface of the gland and is attached to the base of the mandible. Deep layer. So basically, it is derived from the covering is derived from the deep cervical fascia. So the superficial fascia of the deep cervical fascia, the superficial layer of the fascia covers the inferior surface of the gland and attached to the base of the mandible. Deep layer covers the medial surface of the gland and attached to the mylohyoid line of the mandible. Well, the deep part of the gland lies within the floor of the mouth, lying on the mylohyoid lateral to the hypoglossus and the styloglossus. It has three parts: medial, lateral, and inferior. Medial surface, anterior part related to the mylohyoid muscles, nerve to the mylohyoid and submental vessels. The posterior part overlies the hypoglossus muscle, lingual nerve, and the submandibular ganglion, the hypoglossal nerve, and the styloid and the posterior belly of the digastric. Well, the lateral surface lies adjunct to the body of the mandible in the mandibular fossa, insertion of the pterygoid and the facial artery. If we talk of the inferior surface, the skin platysma muscle, the cervical branches of the facial nerve, the deep fascia, the facial vein, and the submandibular lymph. Well, the submandibular duct, also known as the Wharton's duct, is a thin word about 5 cm long. Emerges at the anterior end of the deep part of the gland. Emerges at the anterior end of the deep part of the gland. Runs forward on the hypoglossus between the lingual and the hypoglossal nerve. At the anterior border of the hypoglossus duct, it crosses by the lingual nerve. It opens on the floor of the mouth, on the summit of the sublingual papillae, at the side of the fillum of the tongue. Now here we can see it is crossed by the lingual nerve. This is the lingual nerve. This is the duct. So it is crossed by the sublingual nerve. This is the hypoglossal nerve lying lower to it, and the lingual nerve. So it basically, the Wharton's duct lie between the lingual nerve and the hypoglossal nerve, while the lingual nerve crosses it. Well, if you talk about the blood supply, it is supplied by the submental branch of the facial artery. The venous drainage is the facial and the lingual veins. Lymphatic drainage into the submandibular lymph nodes, deep cervical group, and the zyglo-omohyoid nodes particularly. Applied anatomy, the perivascular lymph node near the facial artery are almost involved in a cancer originating in the submandibular gland, which is removed by the submandibular dissection. So the blood supply, there is submental branch of the facial artery, and venous by the facial and the lingual veins. Now the nerve supply. The supplied by a branch of the submandibular gland, the preganglionic secretomotor fibers, passes from the superior salivary nucleus to the submandibular gland via the facial nerve, the chordae tympani, lingual nerve, and a sympathetic trunk. The postganglionic fibers supply the submandibular gland, and the sympathetic supply from the plexus on the facial artery. Well, the applied anatomy, the formation of the calculus is more common in the submandibular gland than the parotid. Why? The coelolithiasis calculated most common in the submandibular gland due to the following reasons: the viscoserous mucinous secretion, the viscid seromucinous secretion, the long and the curved duct. The long and curved duct, the calcium salts and secretion, the antigradative drainage. A stone in the submandibular duct Waterns can be palpated bimanually in the floor of the mouth and can even be seen if sufficiently large. Now comes the sublingual gland. The smallest of all the salivary glands is almond in shape and weighed approximately 4 grams. Like parotid gland, it was 25 grams. Submandibular was 7 to 16 grams. It is 4 grams. So lying in the floor of the mouth on the superior surface of the mylohyoid muscle and are separated from the oral cavity by a thin layer of mucosa. Here we can see these are the sublingual salivary gland lying over the mylohyoid muscle and separated by the floor by a thin layer of mucosa. The duct of the sublingual is called the Bartholin's duct. Of the parotid, it's called the Stenson's. Of the submandibular, it's called the Wharton's. But the duct of the sublingual gland is called the Bartholin's duct. In most cases, the Bartholin ducts consist of 8 to 20 small ducts of Rivinus. These ducts are short and small in diameter. The ducts of the Rivinus either open individually onto the floor of the mouth near the punctum of the Wharton's duct, or create a sublingual mucosa called the plica sublingualis, open directly into the Wharton's duct. Now, vessels and nerves. The blood supply is via the submental and the sublingual vessels. So the blood vessel is by the submental. The blood supply is by the submental and sublingual vessels, same as the submandibular. Whereas the nerve supply is similar to the submandibular gland. Now comes the minor salivary glands. The minor salivary glands are 600 to 1000. Simple ducts: buccal, labial, palatal, and lingual. Thank you.